as we make our way lower onto the tibia and fibia, right? Tib fib, right? This is your long bone splinting, right? You guys are familiar with this. What's so special about this in New York City? Usually, right, when we initiate IO axis, what I mean by IO, I'm talking about the intraosseous axis. We usually initiate by the tibial tuberosity, right? So if you have done, well, you have not done ALS rotations, but if you work in a 9-1 system and you had ALS responding to you for cardiac arrest, and you saw them drilling, right, this IO device into someone in cardiac arrest if they had hard time gaining AV access, this is the tibial tuberosity, right? Where they would initiate it. Why? Because highly vascular trabecular network, right? A lot of veins, arteries run there, and that's where they will input, right, the medications there. What I want to focus on here, right, especially with the tibia, fibia of the long bones, right, the type of bones. One thing that you want to be familiar with this, right, as we said, right, in the kids, right, in pediatrics, we talked about the epiphyseal plate, right? So the top portion was the, as we go down there, we're going to go to the diaphysis. The very tips will be the epiphysis, and physis here is the epiphyseal plate. This is from where the bone extends in terms of growth, right? So how does it look? This is how it looks. So here we have the actual plate itself, and you notice, right, the ossification zone. This is basically means that the bone has formed. As you go higher up, there's calcified cartilage, and there's zone of hypertrophy. Hypertrophy means growth, and there is proliferating zone. That means that the bone is extending, it's growing, right? And any damage to the epiphyseal plate, you may essentially cause the child essentially growth retardation. They will not continue the growth from the growth plate. So whenever you're inputting your IO axis, I'm going to show you pictures how you would assess this, but you want to be careful not to damage the epiphyseal plate, which is responsible for extension of the bone. So here's just this is more of a close-up view. Here the length increases, right, of the material as it extends, and right here as it extends, right, the calcified cartilage becomes bone. This is just an X-ray image showing you, right. This is actually a fracture of the epiphyseal plate. So a kid coming in with a fracture to the epiphyseal plate, when the doctors come see him, he may have problems, right, with essentially that growth of that bone. So they will be assessing that and seeing, if they can correct. So the tips of the long bones have these plates, right, both here, right. You see one here. Here you see the fracture. So here you go, right? So the growth plate shows you here is all the way towards the top. So proximal tibia, right? And here is where you want to be, right? Why? Because that bone will be more calcified, right? Or let's say more mature bone as opposed to the bone here that's still being formed. So you don't want to be very, very top on the tibial tuberosity when you're starting this in the kids, right? This is their femur. Femur also has the epiphyseal plate, right? So you want to be careful, right? They show you, growth plate here, but the very tips on the epiphyses, right, is where the growth plate will be. So you want to avoid that if you can, right? Not to damage it, so the baby can grow. This is just an image. This is from the science of the Easy IO by Arrow, and they show you in their manual. They'll say, right, the catheters are placed proximally, right, towards the epiphysis end, right, the ends of the bones. Why? Because they're more vascular here. and they have the abundance of the spongy bone or the trabeculae, right? And here you see, right, all the arterial and the vein supply here. So if I'll have my access, right, with my needle, I can go ahead and give my medications through it. Right? This is how it looks. Here's the epiphysis. This is the diaphysis. This is the shaft. Usually, in the kids, right, you don't want to be all the way up here. You want to be lower down, right, by the um, tuberosity, and this is where you want to cannulate. So we will show you in the lab when you essentially drill in. You're going to use a catheter to confirm you're going to get a return of bone marrow, right? And this is how we confirm that we're correct in the correct location. And usually, yeah, the locations of the placement will be the tibia here for New York City region. There's other places that you can employ, right? Where can you basically place the IO? You will see sternal IOs, you will see humeral IOs. Those sites can be accessed if need be. However, be cognizant, right? For example, you got a guy who is in cardiac arrest. Do I really want to start a sternal IO? Right? Maybe not, because I want to be doing chest compressions and that can easily get dislodged, right? But if I put it on the tibial side of it, on the leg, this is not in the way, right, of me doing chest compressions or any other things, right? So this is something you want to keep in mind. This is what I talked about earlier. This is knowing the patients you're dealing with, and essentially their skin, right? If the patient is towards the obese side, they'll have more adipocytes on their skin before you come to the bone. So if I take in a properly sized needle, so I drill it down and I only get right to my subcutaneous fat tissue, right? What's going to happen if I start infusing my medications through this needle?
It's not going to reach where you want it to.
Yeah. Not only that, depending on the medication, right? Depending on the medication, you may cause tissue necrosis, right? So let's say if you start to infuse things like dopamine, levofed, right, your vasopressor medications, and they get infused, not into the vessel, but into your subcutaneous tissue, right, or fat tissue, you can essentially cause damage to that patient. So we always want to pick appropriate size needle. You always want to have confirmation of that bone marrow return, because here, if I was gonna take my flush, right, if I take my flush and I connect it right here and I pull back on my plunger, there's no way I'm gonna get bone marrow return. Why? Because I'm not in the correct location. So here, if this occurred, I would remove this, right, and probably take a longer needle, and find a slightly different site, to insert, and maybe use a different leg if I can. The other thing, this is more of is going to be more of a skill. The reason why I want to include it here is that I just want you to be cognizant of this. Any type of IV bag that you're going to infuse through the IO needle needs to have a pressure infuser bag, right? Or needs to have pressure of about 300 millimeters of mercury. If any of you work in 911 system and you saw paramedics do a cardiac arrest and they start IO access and they put a IV bag, they may either throw a blood pressure cuff around it and they pump it up, or they may give it to you and say squeeze on it, right? Anyone seen that?
Yes, I saw it. Yes.
Yeah, you see. So Aaron says, yeah, he saw it. The reason why is that if you don't apply, a pressure bag, or squeeze on the bag, or put a blood pressure cuff on it, it will not flow, right? You need to overcome that resistance with higher pressure to infuse. One thing I will teach you is this. It's very important. Once you establish the IO access and you confirm with the flush that you get bone marrow return, you first connect your bag without any pressure. Why? Because if I put my bag, right, my IV bag right away into the pressure device and I pump it up to 300 and I connect it to my IO, right, I'm gonna blow a lot of pressure right away. So what you want to do is you want to start the regular bag normally, right? Run it open, then you put the pressure infuser on it, pump it up. or put up a BP cuff on it, pump it up, in that way. So don't right away put the 300 millimeters of mercury and connect it to the IO side. First, connect the regular bag, start running it, then put it into the pressure infuser and slowly pump it up. As you're slowly pumping it up, that increased pressure will facilitate flow. Make sense? So the one thing I also want to say is they also say, right, if you have someone squeezing the bag, this will not attain, right, consistent flow. And that makes sense, right? Let's say I'm on scene, I'm the EMT, you're the paramedic, you're like, all right, I put an IO, here's a bag, squeezing it with your hands. Initially I may have strength to do this, but as the cardiac arrest proceeds, I'm getting tired, I'm not squeezing at the right pressure, right? So you may, not have consistent flow. So the best thing to do is to have the pressure infuser that you could regulate how much millimeters of mercury, right? You could pump this up. It's basically, it looks exactly like a sleeve with a blood pressure cuff manometer, and you just pump it up to 300. As your bag is used up, like as more fluid is going to the patient, you may need to pump this up periodically to maintain the 300 millimeters of mercury pressure. Right? The other important thing. Right, you can establish this device in patients who you cannot gain IV access, but some contraindications I want to talk about, which is pertinent to the bone lecture, right? Anyone heard of this disease process called osteogenesis imperfecta? Does anyone know what that is?
I heard about it, but I really not in my mind. I hear about it before. Yeah, osteogenesis imperfecta. It's like incomplete, like proliferation of
brittle bone disease, right?
Yeah. So yes, you guys are coming on the right path, right? So brittle bone, right? So there's some issue with the bone formation. Yes, correct. So here, this was from the manual from the EasyIO. They basically say if a patient has osteogenesis imperfecta, I'll show you exactly what this disease is. But what they say, it's not it's not an absolute contraindication. Absolute contraindication means you absolutely cannot start this procedure. So that means it's relative. It means upon your assessment, you may or may not go with this, right? But it's not an absolute contraindication. So, but what did they found is that they had a case where they had essentially adult male patient cardiac arrest, and he had osteogenesis imperfecta, and they placed an IO catheter into him. They had they had problems, right? They said that this IO catheter immediately became loose, and they had problems securing the device in place, right? And the patient had type 3 osteogenesis imperfecta, basically severe form of the disease. Usually those kids who have osteogenesis imperfecta, they don't survive to an adulthood. But yeah, it's a brittle bone disease. But and it's a relative contraindication, meaning it's up to your discretion to determine, right? Should you initiate IO access or not? What's the problem with this? We talked about collagen, right? We said collagen is responsible in the skin, right? Keeps that form, but also it's responsible for the matrix of the bone formation, right? It's a large part of the bone formation. It strengthens the ligaments, tendons, skin. That's why you see people getting collagen implants, right? If the skin starts to sag. But in terms of the bones, right? You see here the collagen, right? It also offers this component, right? In the extracellular matrix. And the problem that you will see, right? So before the problem, so the sequence of this collagen, right? The sequence means of the proteins that make this up, or should I want to say amino acids, individual amino acids that make up, right, the sequence of a polypeptide being the protein of collagen. And when they looked at it, right, they sequenced this, and they determined that they have this amino acids called glycine, right? Glycine, right? And here you notice, right, is 1, 2, 3, 1, 2, 3, right? So 1, 2, 3. So every third amino acid in the sequence was glycine, right? So they looked at the primary sequence and they said, well, how come, right? What's so special about it? So the speciality of the glycine, right, is that glycine's its side chain is very small, right? So glycine is the glycine R group is only hydrogen. So this portion here of glycine is very, very tiny compared to, you know, another amino acid like proline, right? You see how big this is? This is just hydrogen. Hydrogen is very small. And this helps in formation of that collagen, right, matrix, having this glycine. And the problem with osteogenesis imperfecta is that this glycine in every third position has been mutated, right, with a genetic disorder, so that there's some other amino acid. So instead of having glycine in every third position, and maybe some other amino acid here, right, histidine, glutamine, or anything else, right? So the problem comes in is that you no longer has this nice sequence, right? And they develop this disease process, right? You'll see their bones malformed, as Ian said, you know, brittle bone disease. So their bone matrix is not as robust because there's no glycine in every third position, right? It's been replaced in that formation. You have more bone fractures. You may have curvature. You have poor muscle tone because of all these factors. And what you got to remember, right, is if you find a baby, right, or you find you know, a teenager, or if they happen to become an adult and they have this type of disease, osteogenesis imperfecta, especially for your IO cannulation, right, it will not be as easily you know, secured in them, right? So it will fall out. You will not be able to secure it, and you may not be able to give your medications properly. So just to tie this up all together, right? We talked about collagen, right? And it helps in your skin and also in your bone, gives that mesh like structure. Collagen has glycine in every third position, right? But in this disease process, osteogenesis imperfecta, there's a mutation, it's a genetic disorder. And because of this, right, the bones are not formed as healthy bones. They have essentially brittle bone disease. And one consequence of this is it's a relative contraindication for an IO. So this is the reason why I like to give you these examples, is that this way you could kind of see, right, you know, you're learning this anatomy, physiology, but how does it relate to your, you know, to you in the field? And the way it relates to you in the field is that here you kind of get an idea, okay, so I know I have an IO I can employ, but I know that, you know, in this disease process, you know, the collagen is not as robust, right? There's no glycine in every third position, and we may have an issue. Martin, you had a question? You kind of breaking up. How about you type in the chat what you want to say, because I did not really hear your message, but if you type it in the chat, I will definitely see it and I will respond to you. So type your question in the chat. In the meantime, right, so as I said, right, so the mutation is here, right, on the third portion of the glycine amino acid, right, and you have this occurring. So the question is, what do you do when you can't get an IV access, and due to the IO you can't get stable IO access? So if you cannot get IV access, right, and due to this you cannot get a stable access, you essentially have a problem. True response, the only way this could be remedied is you would have to basically take them to the hospital so they could get a central IV access. So the doctors will put an ultrasound and they will run, right, the catheter, right, into their subclavian, right, or to internal jugular, and they'll get a central cannulation. In terms of what you can do is you could try having you and your partner start IV access. If you're unable to do so, your next mode of action would be the IO, but know that in this type of disease process, right, it may not be effective because it will not remain in place. And more importantly, if you're using medications like dopamine or pressors, levophed, if they extravasate, meaning if they come out of the intended site, they can cause necrosis of the tissue. So the patient may suffer, right? So in that regard, what you're going to do is just stabilize their ABCs. You may not be able to give any medications or infuse any fluids. You will essentially give you a notification, take them to the hospital, and hopefully in the hospital, under the guidance of ultrasound, the doctors will put a central line, right, through the subclavian axis or through the internal jugular, and then they'll be able to give the appropriate medications. Does that answer your question? Yeah, so, sometimes in the field, you cannot gain IV access. And, if you cannot gain IV access, you cannot gain IV access. I had instances where I couldn't gain IV access, and the person had bilateral below knee amputations, and diabetes, and it was a poor vasculature. So in those cases, right, you may not get IV access. What you do is, you make sure, right, you stabilize your ABCs. So airway, breathing, circulations are under your control. You may not be able to give medications or IV fluids. Give you a notification, and transport them to the closest receiving facility. All right. So the next thing that is also pertinent, we were talking about tibia and fibia, right? Is something known as development of the compartment syndrome. Here you basically see a cross section of the lower leg. Here you have the fibia. Here you have the tibia, right? The two bones. And here you have different compartments. You have the anterior compartment, lateral compartment, right? Superficial posterior compartment, and deep posterior compartment. So you have these compartments. In the center here, you notice there is a nerve supply. There's blood vessels such as arterial supply, venous supply. And the main thing that you may encounter in patients who may have fractures to their tibia and fibia, or they may have a crush, right, injury, is the development of the compartment syndrome. The compartment syndrome means there may be blood pulling or high pressure developing with either one of these compartments, this compartment, this compartment, this compartment, and this in turn presses in, right, closing off supply of blood to the distal circulation, or more distal to the foot. And there may be nerve damage. They may be necrosis of the tissue. In the hospital, what they will do, they have a special device. They'll basically put a needle into the compartment, and they'll measure the pressure that's exerted. But for your purposes, what you want to be remembering is any trauma to the tibia fibia, right? If the patient suffered a fracture there, and when you're splinting it, right, you want to assess for the development of compartment syndrome, right? If they have like pins and needles paresthesia, or they have absence of the pulse of the distal extremity, right? They have pallor of that foot, right? So all of those can be telling you there's a possibility of the compartment syndrome developing, and you want to definitely, right, alert the hospital, give a notification for them. So compartment syndrome will basically cause ischemia and necrosis to the distal tissue because of this pressure basically pushing in forward like this, not allowing blood to go forward, right? The treatment for that, if they cannot relieve it, is they're going to do fasciotomy. So they'll do is they'll go to the OR, and they'll cut a section of the skin. And by cutting the section of the skin, you relieve the pressure in that specific compartment, and hopefully the blood will resume, right? And it will perfuse the distal extremity. So here you have basically a fasciotomy that was performed to treat a compartment syndrome of a patient. It was an upper extremity and secondary to crush injury. So crush injury, any type of fracture to the tib fib, right, will cause that. So be on the lookout, right? And as I said, some of the signs and symptoms could be pulselessness, paresthesia, pallor, right? It'll be maybe some swelling, discoloration of the collar, right? So below the tibia and fibia, right, we have essentially your foot. Here is just showing you the different bones that it's comprised of, right? The metatarsals, the ankle, right, that you see. Usually, trauma or injuries to these bones is not going to be, life-threatening here for the most part. This is just shows you the structure and the different bones that comprise the foot, I should say. we also have different joints, right? That I want to talk about. So the fluids there is synovial fluid, and what does it do is to provide lubrication, right? Shock absorption and nutrient distribution. So let's talk about some of the joints here between the femur and the tibia, right? So you have the joint capsule, you have the synovial fluid that's in between them. And as I was saying, right, it provides some shock absorption, right, especially when you walk, when you run. Here, right, you see the smash, right? This is where the IO would be initiated for the patient. Femur, right? Yeah, you could start a femoral IO too. Usually in New York City, the tibial axis is the major portion, right? So in the joint capsule, you see here. Be careful not to put your IO in the joint capsule itself. We have, the pivot joint, right? This is should be a little bit familiar now, right? Atlas was what? Which cervical number? You guys remember? What was Atlas?
C1.
C1, right? And axis was C2, right? We said Atlas was essentially holding, right, the skull or the head in place here. Axis is for rotation. This becomes important again when we're going to do intubation, placing a patient in the sniffing position. And some other terms that you want to be familiar with that deal with the bones is essentially flexion, right? Movement downward, hyperextension, right? Usually for intubation position, you don't want to have them in hyperextension position. Why? Or flexion position. The reason why is flexion position, you will not be able to see the landmarks. Hyperextension, you're also not going to be able to see the landmarks. I talked about in the respiratory video, you want to have the auditory meatus, that's the ear hole, lying to the sternal notch. So you're basically placing padding behind the head to elevate that. But for your purposes, flexion is basically movement forward. Hyperextension is all the way back. Same thing for your arms, flexion, extension, right? Flexion, the biceps is going to be the ones contracted. Extension is the triceps. Flexion, quadriceps muscle is the hamstrings here, right? So these terms you want to be familiar with in terms of just description. Same thing, right? Just give you an example: dorsiflexion, right? And we have plantar flexion or ankle extension. We usually assess this, right? If a person has any type of musculoskeletal injury or they sprain their ankle, I want to check for movement, and I want to see if that causes any pain. I want to check their range of motion. And if you're documenting on your ACR, you could say, all right, upon my assessment, patient was unable to do dorsiflexion, complaining of pain on scale of 0 to 10 being 10, right? Same thing with the plantar flexion, right? This is ankle extension. The other terms you want to be familiar with is abduction and adduction, right? Abduct, I think it's probably easier, right? If the way I would remember this, if you get abducted or someone, takes you away, right? So abduction is away and adduction is towards, right? So you could have arms, legs, right? Upper extremities, lower extremities with abduction, adduction. This is again for basically referencing the body part in question. You may be using these terms, right, when you're writing your ACRs. Supination and pronation. So what a supination is, palms up. Pronation is palms down. If you may have seen this, probably very easy to explain, right? Especially someone exercising, if they're using dumbbells, right? They supinate when they're trying to work out on their biceps. So supination and pronation are the movements employed, right, to engage the both heads of the bicep. So supination, palms up, pronation, palms down. We talked about the joints of the skull of the exoskeleton already, right? We talked about specifically the atlanto-occipital joint, right, and the atlanto-axial joint. So those are the two joints specifically as it relates to C1 and C2 and C2 and C3. Right? When you have a joint injury, we certainly do splint it. What you want to do is you want to first check, right, if there's pulse present on the distal extremity. So you check the radial pulse if it's an upper extremity. If you have absence of pulse, you want to try one time, to align it to see if you have return of pulse. If not, you're going to then continue with your splinting. Just as a reminder, when you have a shoulder joint injury, what type of splint are you going to employ? Anyone remember?
You broke up a lot. We didn't really hear what you said.
Yeah, I'm saying, sorry, I'm showing different joints that you have. As I said, right, they're there to, there are articulations between the bones. They're there to provide, some synovial fluid. And then essentially my question was, I just want to see your splinting of choice for the shoulder joint. What splint would you use if you have a shoulder?
Swath and sling.
Yeah, sling and swath is excellent, right? Shoulder joint. What about the elbow joint? Or knee joint? What type of splints do you commonly employ for those things?
You do that. The
Port
A-frame.
splits.
The A-frame, right? A-frame. Yeah. You basically take, so you would basically put two boards side by side, and the joint will be bent. Same thing for elbow. You could use an A-frame, right? So same thing for the elbow joint. You want to be very cognizant of, check distal pulses, make sure, right, the injury did not stop the flow of blood distally. You want to check if the pulse is still present. But yeah, splinting, you guys said correctly, A-frames are the splint of choice in here, right? This is just showing you when patients have injuries, right, sustained injuries over periods of time, or as they age, right, with osteoporosis and consistent wear and tear, they may have artificial joints, right? They may have artificial shoulder joint, artificial knee joint, artificial hip joint, right? So they'll get those in place where the normal joint was with synovial fluid and all that. What is one of the biggest factors when you have something artificial implanted? Anyone know? What is the danger of having, like, let's say, artificial hip or artificial knee? That the patient may suffer from? You guys can guess. It's not, let me rephrase my question. Normally, right, the joints, right, the joints have synovial fluid. Let me go back to that picture, right? So they have the joint capsule, they have the synovial fluid. We need joints, right, to provide cushioning and support between the bones. And after, wear and tear or some sort of trauma, patient may have a replacement from the normal, joint to one of these artificial ones. And my question would be, what is the patient most susceptible to now that they have an artificial joint?
Intercartilaginous part of the disc in the joint itself, which is be hypertrophied.
Hypertrophied? Well, they may be, but let me put it this: there is more of a acute problem than they may have.
Maybe it's arthritis.
Arthritis will not be really an acute problem per se, but let me just say, so anytime you have something artificial in your body, anything artificial, there is chance of blood coagulation around it. So they'll tend to make more blood clots. Why? Because when the blood, right, sees tissue that's not self, right, it may coagulate, and you need to be cognizant, right, of these patients developing these clots, and they, depending on where this clot may lodge, right, may have pulmonary embolus, they may have CVA. So anytime a patient has anything artificial, right, that's I wouldn't say that's not living tissue, like, like let's say a mechanical valve, or artificial hip, artificial knee, artificial shoulder, any type you have metals, right, in your body, the result of this will be, right, that the patient may suffer, right, possible blood clot formation.